Thank you. So, good morning. Welcome to the July general membership meeting of the Seattle King County Coalition on Homelessness. We are really happy to have you here. We have a fantastic agenda for you. So, just a reminder, if you don't want to be included in the recording, just stay on mute. You can have your camera on. We love to see your beautiful faces. Throw things into the chat if you have a comment or a question or a resource you want to share. If you need closed captioning, that's available at the bottom. You can also change your name, pronouns, tell us how you're associated in your little Zoom box. And additionally, we would love for you to introduce yourself into the chat with each other and share your contact information as available so you all can get to know who you are and what you all do. If you don't mind being included in the recording, just feel free to raise your hand and we'll call on you and you can ask your questions. And then at the very end of the meeting, we have time reserved for member and community announcements. And what we typically do is we tend to invite one organization to sort of kick it off, and we try to include that in the recording, and then we turn the recording off. So if you want to have more of a conversation that's not going to be blasted on YouTube, you can do that. So just keep that in mind. Ping any one of us. So Hallie, Tim, myself, Jody, if you want to be a part of the member announcements, or you can just, in real time participate. I just want to remind folks that we do record all of our meetings and we do preserve meetings and trainings for that matter on our YouTube channel. So warmly and encourage you to check that out. Lots and lots of really great information there. My Zoom is really looking, oh, there we go. I had it on a weird view and I couldn't see any of you and I couldn't see myself, and I found it a little dysregulating to my usual pattern here. As you can see, we've got a really great agenda. So we have been talking about summer EBT because it is so important, and really wanting to make sure that everybody that is eligible for this incredible new benefit has the information they need, and the application is ready. So we have Troy from DSHS to come and share that information that we are really pleased to have them join us. We have the amazing folks from the Telebup Hotline here to come and talk about that fairly new and amazing resource. The Supreme Court, just recently came down with the much anticipated Grants Pass versus Gloria Johnson ruling. And so we are all processing that, digesting that. We want to hear some of your thoughts, your questions, your reactions. We've got big, important elections coming down the road at us. So Tim's going to give us a little primer on that. And then, as I mentioned, we'll have member and community announcements. So if we could switch to our mission, vision, and values, and if I might invite one of you lovely folks to read that, just as part of our community building. And it is the shared values of all of us in the coalition. So anybody willing to read that for us?
I can read it.
Thank you.
Welcome. We mobilize our community to challenge systemic causes of homelessness and advocate for housing justice. Our vision is a region that acts on a shared sense of responsibility to ensure that everyone has a home, living out the values of equity, justice, and collective action.
Beautiful, Kevin. Thank you so much. I appreciate it.
My pleasure.
Thanks for being here. All right, on that note, I'm going to hand it over to my colleague, Tim, to introduce Troy from DSHS. Take it away, Tim.
Fantastic. Thanks, Jody. So Cody mentioned that we just recently had the application launch of a very important public benefit for summer 2024. We've talked about it in the last couple of meetings. So I don't want to go into too great details. If anybody has questions about what Sunbucks is, I'll briefly tell you, it is a one-time $120 payment to K through 12 students in a household. All Washingtonians are eligible if you meet an income threshold. If you essentially are in a low-income household, including people who are not citizens and undocumented. We want to get that out there. We want people to know they can apply for this benefit. Some people don't need to apply. As a reminder, if you're already enrolled in state benefits or have submitted a school meals application form to your school district, you probably don't need to. But for those who do still need to, this application is, I believe, accepting forms until the end of August. So I'm going to post a couple of links in the chat for folks who want familiarity with Sunbucks, and I'm going to pass it over to my colleague Troy from DSHS to show us the application. Thanks so much for being here, Troy.
Hi, everyone. Big thank you, Tim, for inviting me. It's great to be with you all this morning. My name is Troy Burgess. I'm a program manager with the Department of Social and Health Services, Community Services Division. I am based out of Tacoma. Happy here to talk about Sunbucks. If I'm able to, I can go ahead and share my screen real fast. Okay, can everyone see the screen okay?
Looks good.
Perfect. So, yeah, big thank you, Tim, for doing a little recap. You did an excellent job. So, yeah, Sunbucks is a brand new permanent program that just started this year. Was authorized through the Consolidated Appropriations Act 2023, and it is supporting children during the summer break while school session is out. We do plan to support the program pending funding and state plan approval for the future years to come, and we're excited to be able to put the first year together in quite a significant short amount of time. But I wouldn't have been able to help implement this program without our internal, external partners, leadership support. So yeah, let's talk about the Sunbucks application. So what you see on the screen is the Sunbucks application portal. This is sunbucks.dshs.wa.gov. And the Sunbucks online application launched July 1st. And as Tim mentioned, it is open through August 31st of this year. And this is part of our defined summer period. So regulations require us to establish a summer period that's reflective of when schools generally are out of session for the school year. So our summer period is June 1st through August 31st, 2024. So during this time, families are able to apply, families who are required to apply for Sunbucks will submit their application through this online portal. And a couple things I'd like to mention about this application portal. One, so it is available automatically in English and Spanish. We worked hard to make sure that there's supported languages throughout. And for the primary is English and Spanish. Our Sunbucks Contact Center also has additional language support for anybody who might require those. So for the application portal itself, a couple things I would like to call out. So one, there's a screening tool. So as Tim mentioned, there's not every child has to apply for Sunbucks. The majority of the 550,000 children that we estimate in Washington are expected to approve automatically. And that is based on eligibility data from Department of Social and Health Services and working with the Office of Superintendent of Public Instruction, partnership of the local K through 12 national school lunch participating schools to receive eligibility data for the children individually approved for free reduced lunch. So we're compiled all this eligibility data and automatically approved. But there are some families out there who might not meet or who may not fall under these umbrellas, so they would apply. So we do try to address applications within 14 business days once they do apply. So when filling out this screening tool. The screening tool is based on an estimate, so it does follow our policy, and it allows families to put in scenarios based on their family to help them understand if they have to apply. And so then on the application piece itself, when they apply for SunBucks, sorry, a little technology is running a little slow here. So when they apply for SunBucks, they'll be able to, they'll be able to create an account to track their confirmation number and the account for their benefits. But if they choose not to, it's not a requirement. They can continue without applying. So there's a bit of disclosure, again, reinforcing that they may not have to apply if they're part of that automatic group. And once they continue through the application and agree to the initial information, they'll be able to start applying. So they'll be able to put details about so the applicant could be a parent or an authorized caregiver, grandparent, custodial parent, whoever the child is residing with, and the benefits could be used on behalf of. So they'll input information regarding themselves, the children, any income that they declare to the household, and then complete the application summary. So one thing I wanted to say about the application is you can't complete the application without inputting all information. We really wanted to make sure that applications are received without missing information, as it could affect eligibility down the road. So the portal was designed to catch if any pertinent information is missing. So, and then at the end, families will be able to review the summary, acknowledge a few disclosures about the program itself, and then it's electronically submitted straight to the vendor that we work with, whose name is Accenture LLC, and they assist in the validation process. So for those who may lack internet access, we do offer a paper application. This is connected on the SunBucks DSHS website. This is the paper version of the application itself, replicated. We do emphasize the importance of the online application if possible, because it does expedite application processing. It's sent directly to our vendor. We do have a process set up for paper applications. It's mailed directly to DSHS and will take some time to go through our document management system straight to the online portal. So again, we do encourage families to submit the online application, but have a paper application if available. The paper application itself is available in a number of supported languages, at least 10, for those who have language needs. And I know I have just a few minutes here, so just a couple other small disclaimers about the program. Our DSHS SunBucks website, which is dshs.gov/sunbucks, does contain information about the program and provides an image of the card, so families who do receive the card can understand that it's a legitimate card and begin to use it. SunBucks do expire within 122 days of deposit from the card, so it's important families use those benefits before they do expire. Unfortunately, they cannot be replaced once they are expired, but families will receive notice of approval when they do apply, and and the card that is mailed to the last reported address on the application will include information on how to activate the card and important information about benefit usage. So, and that is SunBucks from a quick high-level view. You can always reach out to me if you have questions. I can put my email in the chat. I'm happy to help anyone understand the program a bit more. And we are actively working on the second year of SunBucks for the 24-25 academic school year, and excited to continue this program in the future years to come.
Amazing. Thank you so much, Troy. That was very helpful to have you navigate the application with us. Yeah, that's really great. I love seeing that it is launched. I really appreciate your time here. Because we're running a little bit short on time, I do want to direct people, if they have any questions about using the application, to put them in the chat. Troy, thank you so much for sharing your email address. It sounds like Troy could take some questions too. You can also email me, and we could get those answered as well. Awesome. Thank you so much. As a reminder, all of this is going to be posted on our recap blog and our YouTube recording, so it will be available after this meeting for those who have questions about SunBucks.
Appreciate it. Thank you.
Thank you. All right. So let's keep moving to cover our next agenda point. I'm going to pass it over to registered nurse Jody Rao to introduce our next guest, who are going to talk about the Telebup Hotline.
Thanks, Tim. Yeah, folks, Tim and I had the pleasure of having part of the Telebup team join us for the South King County Forum on Homelessness recently. And not only is it just an incredible resource to help with the opioid epidemic that we are all navigating and facing in one way or another, but these folks have such compassion and passion for this work. It really touched my heart. So I'm really excited to introduce Olivia Hood and I believe Dr. Chris Baresh. And I'm not sure if you have any other colleagues on the line that I should be pinning and co-hosting, but I'm going to let them do their brilliant presentation. But this is just, as somebody that hasn't been a direct service nurse for a few years now, this would have been an incredible resource to have had when I was. And so if you do not already know about this, please pay attention. We will be taking notes and gathering resources, so you can just pay attention and ask your beautiful questions. We will get all the resources out to you. So with no further ado, Olivia, I'm going to hand it to you. Thank you both for being here.
Thank you so much, Jody. I really appreciate that introduction. We loved to present to the group last time and are very excited to talk with you all today. So my name is Olivia Hood. I'm the program manager for population health within our Department of Emergency Medicine at UW, and serve as the program manager for this Telebup program since we started on January 2nd. And then my colleague Chris is here today if he'd like to introduce himself as well.
Hey everybody, my name is Chris Burish. I am an emergency medicine physician at Harborview and also at Seattle Children's. I'm also a pediatrician, and I am super excited to talk about this. This project has been probably one of the most professionally rewarding things I've ever done, and it's really great. So I'll take the first part. I think Olivia is gonna do the wrap up, but this is a project that's been funded by Seattle King County Public Health, and then some of the investigators also get additional funding to do other things. But Seattle King County is really sort of the founder of the feast here, and it's been super awesome. So they fund this through the Department of Emergency Medicine. And so everybody that is working on the hotline right now is within the department, and we really appreciate having you guys here today. So what we're going to talk about today is really just sort of, I know this is probably a review for everybody, some very high level opioid crisis epidemiology stuff. We're going to talk a little bit about medications and some kind of brief pharmacology, which I know is probably kind of boring for everyone, and some regulations. And then we'll go through our team and how, like, really kind of the nuts and bolts of how this works, and give you some of the initial kind of data that we've been collecting, which has been really exciting. And so, as you all are certainly aware, there's a lot of folks dying of overdose in King County. Opioids are kind of the number one thing, but a lot of times there's methamphetamine involved as well. And that's just getting worse and worse and worse. And people who are unstably housed or unhoused are really disproportionately affected by this compared to their friends that are housed. And so we, on the hotline, prescribe a medicine called buprenorphine. It's Subutex or Suboxone or some of the brand names. Suboxone is just buprenorphine with naloxone or Narcan mixed into it, so that if you take it the way you're supposed to under your tongue, it's totally fine. But if you were to like kind of crush it up and snort it or inject it or anything like that, the naloxone would kick in and prevent somebody from overdosing, but also would put them into withdrawal, and that's not very nice. So the buprenorphine does a great job of preventing withdrawal symptoms and treating withdrawal symptoms, but also prevents people from having cravings to use. And I think personally, the thing that as a physician is most exciting to me is that if you have a good dose of buprenorphine in your system, even if you take additional fentanyl, like a lot of additional fentanyl, it's really hard for you to overdose to the point that you can't breathe. The buprenorphine is very protective against that. It's approved by the FDA down to age 16. That's where it's been studied. But we use it off-label down to age 13 for people that need it. And so this is kind of how it works. So if you think of, if you maybe click the next 2 or 3 there, Olivia. Sorry, so if you think of, this is sort of the opioid effect kind of on the Y scale, and then the dose on the X scale. And so if you think of like fentanyl or methadone or opium or morphine or any of those drugs, those are full agonists, right? They get into your body and they bind to these receptors in your brain and all over your body. And they bind to those receptors and they make things happen in the cell. It's like turning on a light switch, right? And it turns lights on like 100% and it's very bright. Naloxone, on the other hand, binds to those same receptors and kicks the full agonist off, kicks the fentanyl off, kicks the morphine off, kicks the opium off, and turns those receptors all the way off, right? And so it's totally pitch black, totally dark. Buprenorphine is interesting because it binds even more tightly to the receptors than the other 2 medicines, right? So it'll kick off everything else, but it only turns the lights on about 40% of the way, right? So it's not enough to make people feel sort of that euphoria, or it doesn't make you feel great, but you don't have any withdrawal symptoms, and you don't have it helps with the cravings. And so that is the super cool part of it. So it's like a dimmer switch, right? The lights aren't all the way on, they're not all the way off, they're kind of just right. It's the Goldilocks phenomenon. That QR code there is just a QR code that will link to free naloxone if you live in King County. That's provided by PRA and the county. And so if you want to take a quick picture of that or screenshot that and order yourself some naloxone, I think everybody should have some on them. All right, can you go to the next slide there, Olivia? Yeah, thank you, Allison. PRA's amazing. So we already kind of talked about this, but I think that by getting folks that are having chaotic drug use on buprenorphine, it does reduce the risk of overdose, which is huge, and reduces the number of days that they use other like fentanyl. But it really helps with mortality. And I think what we've been finding when we've been hearing from people that have been coming through the hotline when we talk to them again, is that it really just sort of buys them some bandwidth, like to focus on other things, right? They're not constantly worried about how to stay well, how to not get sick, whether, it's like they can do stuff. They can find jobs, they can apply for housing. We've talked to people that are getting their kids back. It is really kind of a life-changing thing for people that get on it and stay on it. And so unfortunately, there's not very many people that do get on it and stay on it, right? Only about 1 in 5 people that have opioid use disorder, as of 2020, were on MOUD. And that's just not acceptable, right? It's just, so we need to increase access in ways that, and give people access in ways where they don't feel judged and they feel supported, and it's there for them when they need it, right? You don't have to make an appointment and wait for a couple of weeks or whatever, or drive halfway across the state. And so that's kind of where this hotline comes in. And we've been able to do this because of some changing in federal regulations that happened around the pandemic that allowed, for the longest time, you couldn't prescribe opioids or any scheduled medications over the phone because they were worried about pill mills. And then with the pandemic, they relaxed some of those regulations. And then just a couple of months ago, they made those regulations permanent, which is awesome. So, and so we have this amazing team put together. And Olivia, I'm kind of losing track of the number of slides we're on, so just tell me when you need to take over.
Right.
But let me just introduce you real quick. So we have this really super incredible team. So Olivia really is the brains and the brawn behind this whole thing, and makes it run and does a lot of our internal communication, external communication, organizing schedules, keeping people together. We have 13 faculty members from the emergency department that take turns being on call. And so I was on call last night, and I'm on call till 6 o'clock tonight. If you guys need anything, hit me up on my cell. So we take turns doing that. And then really the magic and the superheroes are like care coordinators. And so it's pretty easy just to send somebody a prescription. That's not a big deal. Where the real benefit comes, where the real awesomeness is is that our language care coordinators will then call people back in about 72 hours just to check in, be like, hey, did you get your meds? Are you having any trouble with them? Does the dose feel right to you? Do you need any additional medications? You know, and then how do we get you hooked up with somebody who can do ongoing care, right? Because this hotline is really kind of like a stopgap safety net thing. It's not like we don't provide ongoing care for people. You wouldn't want us doing that. We're all emergency doctors and terrible at that kind of stuff. So, so we get people hooked up with the real pros who can kind of dial in their dose and help with some of the other things. And also we can help, you know, with transportation and other barriers to care. All right, and so we started on January 2nd. We have, I think we have 13 providers now. I think we've got to update this. We have 2 language care coordinators. We have Olivia, and we have a few other people helping out. And so, and our goal really is to be, you know, very patient-centered, right? I think we recognize that a lot of the people that are calling us have been through a lot, you know, and there's been trauma, and there's been stigma, and there's been just a lot of awfulness, honestly. And we really want to be there with people and for people, and we want to really celebrate the fact that they're calling. Like, it's pretty amazing, right? It's a huge opportunity to change things. I think even when people call back 2 or 3 times, you know, the fact that they are still engaged, they haven't given up, they want to try again. You know, we kind of love that. So we try to be as empathetic and respectful as possible. We try to be as accessible as possible. And then we try to, like, you know, respect people's time and not keep them on the phone forever and get back to them right away. And so, yeah. And I think philosophically, we kind of had this conversation before we even started about distributing lots of buprenorphine, right? I think you could say, gosh, are we just kind of shelling out buprenorphine to everyone around like kind of the Candyman syndrome, you know, and handing out buprenorphine all over the place? And is that going to lead to buprenorphine overdose? And I don't really think that that's a thing, right? Like, I think if people take too much, they feel kind of crappy, but they don't stop breathing. At least adults. Kids can stop breathing, but adults won't stop breathing with buprenorphine. So I'm not as worried about buprenorphine overdose. You know, I think diversion is a risk, right? And I think that maybe people are going to have friends who are in withdrawal and be like, here, try some of my bupe. And while that is technically illegal and naughty and shame, like, I don't care. You know, like, I know it's being recorded, so officially you're not supposed to do that. And I want to be very clear that that's not legal. I think practically, if you're helping somebody stay out of withdrawal and you're preventing somebody from using fentanyl because they're super sick, then you're a freaking superhero, and that's amazing. But that's not my official statement. So I think, you know, the downside is, you know, if we don't give out enough buprenorphine, then people will, you know, if we start people on too low a dose, or we're not there when they need us, or, you know, then people are going to struggle, right? They're not going to get started on treatment. They get started on treatment like at the wrong time and the wrong dose without any guidance, and they're going to have precipitated withdrawal and feel awful and like never want to do it again. They'll continue to use fentanyl because nobody wants to be sick, and there's going to be more overdose and death. So I guess as we think about what we're doing and why we're doing it, it seems like if we're going to err, we want to err on the side of giving out more buprenorphine than less, is the whole big point of that. And so we usually start people on, usually most people 24 milligrams a day. So we have 8 milligram strips or tabs they can put into their tongue. We have them do that 3 times a day. Sometimes we'll go a little higher than that, especially on the first day, because we ask people to be in some moderate withdrawal before they start the medicine, so that they don't get sick right away, like that, so that medicine doesn't put them in precipitated withdrawal. And so sometimes that first dose really needs to be more like 16 milligrams to kind of make them well faster, and then they can start on the 8 milligrams 3 times a day. And then we give lots of other medications too to help people be comfortable and treat the most bothersome withdrawal symptoms. And I should say, and I should have mentioned this when we had my little pharmacology graph, you know, the problem with the precipitated withdrawal, right, is that if the lights are on at 100% because you just smoked some fentanyl an hour ago, and then you take buprenorphine and you suddenly dim the room to 40%, you feel like crap, right? And so that's what precipitated withdrawal is, going from 100% to 40%, and then suddenly you're sick as can be, and you're miserable, and you hate it, and it's hard to treat. We just give more and more buprenorphine to try and get people to a place where they can cope. But it's awful and nobody wants to go through that. And so it's really important when you're starting buprenorphine for the first time to be in withdrawal, at least, moderate withdrawal, to be kind of sick before you start it, so you don't have to go through that. And so then once we're done talking to folks and we send them a prescription to any pharmacy in the state of Washington that's nearby, we will then send them instructions on how to start, kind of hammering home that point that you have to be in withdrawal before you start. And these are really based on some other kind of evidence-based pathways from California. The state of Washington's got one now called Scala Northwest, and kind of what we do in our OBOT clinic. And we just really believe that, like, underdosing is harmful, not treating this aggressively is harmful. We need to be patient-centered and be there for people. And I don't think diversion actually happens all that often. And when it does, I'm all about, like, the under the table high five. So yeah. All right, so these are the instructions we give to people is, when you first get your medicine, we want you to be in moderate withdrawal. Go ahead and take 2 films. If you're feeling pretty sick, that's 16 milligrams. And then you can take an additional 1 or 2 films, so up to 4 films that first day. And then most people do pretty well with 1 film 3 times a day going forwards. And so we feel like that kind of the way that the medicine sort of goes up and comes down, we feel like dosing that 3 times a day keeps people at a pretty good steady state instead of doing like all 3 films at once.
Hey, thank you so much, Chris. I'm really glad that Chris is here to talk to you all today. He is actually our top testing or our top provider for Telebup. He's seen the most patients that we've had through the program since January 2nd out of those 13 providers. So it's really awesome that you were able to hear from him today. I want to talk you through some of our program logistics. So what this actually looks like for your patients when they call into the Telebup hotline. And before I jump into that, I would just like to say a couple more things about our program philosophy that Chris touched on, is that when we created this program after we saw the RFP released from King County, our goal of this was to be as low barrier as possible, so that if a patient had the choice of calling us to get help or calling someone to use, it was the same, and that they could call us just as easy as they could call to go get more fentanyl. As we've seen with our patients, is that is a lot easier than you would realize sometimes. We've been on the phone with patients before, and within about 4 minutes, they have gone downstairs in their apartment complex and came back up with a dose of fentanyl, right? So it is extremely accessible to folks in King County and throughout the nation, but especially in this urban area. And we want to be just as accessible and low barrier for them. So whether it is on your lunch break and you are ready for a buprenorphine prescription, or if it is 2 o'clock in the morning and you're finally ready to take that step in your recovery journey, whether it's the morning after you've overdosed for the first time, or if you're hiding in a pantry from your kids, we're there for you. And that is our model for our program, to be accessible for everyone. So let's talk about weekdays for when patients come in. As Chris talked about, our linkage to care coordinators are the superheroes of our Telebup program, and nothing would happen without them. They staff the hotline 8 a.m. to 6 p.m. Monday through Friday. So a patient is ready to talk about buprenorphine and see if it's the right fit for them. They're going to call into our hotline, and who they'll get is one of our linkage to care coordinators. They will go over a couple questions with them, such as, are you in the state of Washington? Are you calling for buprenorphine for opioid use disorder? And my clarifying point for that is that we will not prescribe buprenorphine for chronic pain. And that is something that we receive a request for commonly, but this program is solely for those with opioid use disorder. If you have both, which we have patients for, we do work to prescribe to you and get you connected to long-term care, but this is not just a chronic pain program. Our target audience is those with opioid use disorder. So you will get connected to the linkage to care coordinator. They're going to ask your first and last name, your date of birth, a callback number, and that you're in the state of Washington, and confirm what you're calling for. After that, they're going to ask if you prefer audio or a video visit. I'll be honest with you, 99.9% of patients all prefer audio, so they want a phone call back. And at that point, such as Chris is on shift today, the provider that is on call will call that patient back within about 30 minutes. That's dependent. If they're on the phone with other patients, it may take a little bit longer if we have a longer queue, but it's typically always under 30 minutes that the provider will call the patient back after they've first done their intake. So the provider calls the patient back. They do a visit that ranges anywhere from 15 to about 40 minutes. This is dependent on if they've been on buprenorphine before or not. So we receive a lot of folks that have been recently incarcerated. They were on a stable dose of buprenorphine in jail. They've been released without a prescription, and they need more, but they've already been stable. They know what they need. They know how to take it. They don't need as long of a visit as someone that this is the first time they've ever admitted their addiction to anyone. They have a lot of concerns about the efficacy of buprenorphine, want to talk through that with their provider. And those visits are typically where you would see around 40 minutes or more when they have more in-depth. So at that point, the provider will send the prescription to the pharmacy of the patient's choice, as long as it's in Washington state. And then the patient will go pick up that prescription. If they have any barriers to pick up that prescription, they call us back and we help with it. That is the beauty of being a 24/7 hotline, is that we are always there for their assistance for any barriers they need. And one important point that I want to make for this is that this is a non-billable service. So we do not charge anyone for this visit when they call into the hotline. It is free. However, we cannot guarantee that your medication will be free. So we do our best to make sure that you have insurance coverage, or we get you in a walk-in clinic that can provide it to you for free if you don't have coverage. And that's where our linkage to care coordinators come in. Okay, and then what happens when those linkage to care coordinators aren't around? The phone call actually goes straight to the provider. So after hours during the week, so 6 p.m. to 8 a.m. and every single weekend, the provider on call manages the phone themselves. So they will go through those same triage questions with the patient and then do the visit right then and there, send the prescription to the pharmacy, and then the patient will pick it up. I will say that you do experience some more barriers on the weekends, just because we don't have access to walk-in clinics if someone doesn't have insurance information, and we don't have the linkage to care coordinators there to mitigate some of the barriers that pop up. So it may mean that you get an extra call back on Monday morning to help you out, but we go above and beyond to help patients out over the weekends. And it's incredible what our providers are willing to do to make sure that these patients get care. I will add to that is that the patients receive a follow-up call 72 hours after their first visit from the linkage to care coordinator to make sure that they were able to pick up their prescription, that they're feeling okay and aren't having some really poor side effects or need more ancillary medications for nausea or sleep maybe, and then to help them get linked to ongoing care. So for our patient experience overall, patients need to be in the state of Washington and 13 years old or over. Treatment for OUD, as I shared earlier, not chronic pain, or to transition from methadone to buprenorphine. That's also an important point and something that we've seen more of lately for patients that have not been able to go to a methadone clinic anymore and they would like to do that switch. I'll be honest with you all, and Chris can touch on this as well, but that can be really dangerous for the patient and they can feel very, very poorly while making that switch. So we recommend that anyone that is titrating down on methadone does that under the care of a clinician in clinic and not through a telehealth platform. We're not equipped to monitor you as you're going from methadone to bup and make sure that you're doing okay. And then, like I said before, we do not bill for our visit, but they do still pay for their medication. Most everyone is covered by insurance, but if not, the linkage to care coordinators will help you set that up. Even if they have been recently released, they'll help them get their insurance reactivated. And then they will connect them to ongoing care. So for the longitudinal care models, they will also help them get connected to a PCP if they need it, a behavioral health evaluation, alcohol use disorder treatment for HIV, hepatitis C, or STIs. And then up to 3 prescriptions in 3 months. So our program policy is that we are not a longitudinal care model. We're not equipped for that. And we want these patients to be in a care model that they can have a hands-on clinician to carry them through this recovery journey. So we will give you 2 prescriptions within 2 weeks or 3 prescriptions within 3 months. But our goal is to engage you in a longitudinal care model. Okay, a little bit more about these linkage to care coordinators. As I said before, they are on Monday through Friday, 8 a.m. to 6 p.m. So especially for those in this group, if you have a patient that is called in and you need some extra resources or questions, that's the time to call in to speak with these linkage to care coordinators. They reach out within 72 hours after the first visit, and they continue reaching out. Most patients have an average of 10 plus outreach attempts by our linkage to care coordinators to get them linked to ongoing care. And then we link our patients to over 10 referral partners within King County and within the state. This is based on several different things. First, whether they have insurance or they will be doing self-pay, whether they have a preference for telehealth or in person. About 20% of our patients would like to continue with a telehealth model, which we utilize the platform's clinic and Boulder Care for, their location preference, and then other services that they require. So just to give you an overview of how this has worked since January 2nd is that this week exactly we have hit over 250 patients. So we are at our 252 patients. With that, we have over 300 patient encounters. So a handful of those patients have come back to us a second or third time to continue getting buprenorphine scripts because they were experiencing more barriers, and we've been happy to help them. 99.2% of the patients that call into us are diagnosed with opioid use disorder, and 99.1% are prescribed buprenorphine. That little population of patients that aren't prescribed buprenorphine typically are a better fit for methadone or need chronic pain management, which is why we don't prescribe to them. Referred for ongoing care, 61.5% of our patients were referred for ongoing care, whether they were scheduled with someone, sent to Boulder Care for telehealth, or a walk-in clinic within King County. Pathways and Hobson Clinic are our two biggest partners for that. 94.7% were actually bridge prescriptions. So they were already established in care, but let's say it's a Friday afternoon, they missed their appointment, but they're out of their buprenorphine for the weekend. Instead of them going without, they can call us, we get them a bridge prescription until they can get in to see their provider next. And that has been very successful for our patients. And we've gotten wonderful feedback from them for having this opportunity to continue their care when their clinic may not facilitate that. And then we have lost 12.8% of patients to follow-up. This is a mix of changing contact information, especially for our unhoused patients. Sometimes their phones get lost, stolen, or their plan is up and they don't have any minutes left. We also have a handful of patients that have been reincarcerated and have been lost to follow-up in that sense. Our patient demographics, 61% male and 39% female. That's been pretty consistent since we've started the Telebup program. We do have 47% of a white population. That unknown, however, is patient information that we have not been able to gather at triage. So typically those are patients that are new to the University of Washington system. So we expect that this is an even more diverse group than this pie chart is showing. But I will say our Black and African American population has been continually increasing since we've started the Telebup program, as well as our diversity. Okay, and then please connect with us. This is our hotline phone number, our email address, and our website. I will also put my personal email address in the chat if you would ever like to reach out to me, get more information on Telebup, or have questions about how this can work for your patients. However, please feel free to call in for that as well, and our linkage to care coordinators would love to help you. All right, thank you all today. And if you have any questions, we'd be happy to answer them.
Oh my goodness. Thank you, Olivia and Chris. What a great presentation. We do have a couple minutes for some questions. So I am going to, for the benefit of the recording, we did have a question in the chat that said, do you know the approximate cost of the medication? And thank you, Dr. Chris, if I may, putting in the chat that the Telebup visit is free. The medicine is often covered by insurance, but for folks that don't have insurance, they use the GoodRx, and the link was thrown into the chat to try to find the cheapest pharmacy nearby and to use that coupon. Do y'all have a sense that even with the GoodRx, roughly what the range can be, or is it just wildly different?
I mean, I think it's pretty reasonable. I think it's like $15 to $20 for 14 films, 15 to $25. And so, but when we're using 3 films a day, that doesn't last you super long. And so so it is kind of always a bit of a balancing act, right? Because we want to, so I think sometimes the easiest thing to do is to give people like a 5-day prescription, and then our linkage care coordinators can call them and follow up and see if we can get them hooked up with, enrolled in insurance, which will then work retroactively, and then we can give them a longer prescription after that. but it's tricky. You know, sometimes we'll just talk to pharmacies and allow them to do a partial fill so that they don't, you know, we give them the 2-week prescription, but they just kind of fill the first couple, 3 or 4 days. And so it is a hard thing to manage though, because it's not free, and unfortunately there's just not much we can do about that.
I appreciate that extra information and your comment that our dear and beloved colleagues over at King County are also working on this part of the issue to make it even more accessible.
They are, and I think if anybody can successfully like joust that windmill, it'd be Brett Good. Yeah.
Agreed. I know Allison has a question, but I just want to hold in case any of our providers on the call have a question that they're mulling over, typing, building up the courage to click unmute. Okay, well, we'll give you a little bit more and I'll pass the floor to Allison for her question. And then if we've got maybe one question that somebody they're mulling over, we can go to that and then we'll move on to the next section. So Allison, take it away.
Thank you so much, Jody, and thank you very much, Olivia and Chris. It's great to hear the thinking behind the design of this effort, and really to get some exciting, impressive, and I would say hope-filling information about how things have been going so far. I will say, you know, this is such a grave crisis. I was in a meeting yesterday with a colleague from one of our member organizations who said that even with naloxone everywhere in all their properties, they had 6 of their residents pass away due to overdoses in a one week period. So there is a shocking need for these and other services. And my question really is whether or not you and your colleagues have any insights that you may be developing about how this is working for folks experiencing homelessness in particular. Do you have any anecdotal or hard data that would be useful to share, even in a preliminary way, or any questions for folks here who serve people experiencing homelessness about how what you just described might be made even more accessible?
Oh, that's a great question. I think, I mean, yeah, this is definitely preaching to the choir. I think this is especially a big deal for people who are homeless, right? I think people who are homeless often are using, methamphetamine and, opioids for a lot of different reasons, right? That make a lot of sense. Like, they're great coping mechanisms for some of the things that they have been through or are going through. And I think that makes it especially difficult for them to quit. I do think that sometimes giving people 2 weeks worth of buprenorphine, it's awfully hard for them to hang on to that, right? I mean, there's some value to it, and so we've had a few people that have been unstably housed that call back pretty often because they keep getting beat up and people take their bupe. I think one answer to that is the long-acting injectable buprenorphine, right? Once it's injected, it's pretty hard for somebody to take it away from you. And eventually, I think that would be an amazing tool. I think in the shorter term, having somewhere safe that they can store their medications with, shelter or somewhere where they can show up and just take their medications a few times a day could be helpful. But also, I recognize it's kind of a pain in the neck for them to have to show up somewhere through. They might as well be on methadone, right? So I recognize that, but you're right, Allison. It's a huge problem, and we, I don't think, have the perfect solution yet. And I think, it'd be interesting to explore sort of like a co-design with people that are experiencing homelessness, right? How can we kind of tweak things or revamp things to make this a little more usable for them? I apologize. I'm going to have to go because I am supposed to be actually introducing another speaker at another meeting. And so, but thank you everybody for your time.
Thank you
Chris.
so much. We are going to take Karina's question and then we are going to move on in our agenda. So Karina, please ask your question.
Forgive me because I do not know very much about this, so this might sound like a stupid question, but how do the films stand up in the heat? how is this medication cold or hot? Like, is it affected by temperature or getting wet?
That is a wonderful question. I've actually never been asked that before, so thank you. I need to do a little bit more of background research. To my knowledge, temperature will not affect the films. I assume that if the films get wet, they will though. So let me do a little bit of follow up, and I will send it to Tim within 30 minutes after this meeting, so he can send out to the group if that works. But I will say thank you for asking that. One point that I will make for the films is that they taste terrible for patients. They taste really, really bad, and that can turn a lot of folks off for buprenorphine, which is why we talk about like diversion, right? Is we want to give everyone our tips. So if people are doing films, a lot of times EMS carries around Jolly Ranchers to have, but we also recommend to take a mint as well, but definitely have something else in your mouth while you're taking the films. And then tablets are always a great alternative option as well. Thank you for that question.
Great. Wonderful question, Karina. Olivia, thank you so much for being here. Really appreciate all this great information. Thank you for the good work you're all doing, and appreciate you following up with Tim with that answer. So have a lovely rest of your day. If you are also welcome to hang out with us, we love new guests. So thanks.
Thank you all so much.
Okay, folks, don't hesitate to keep throwing questions in the chat. If you're mulling stuff, we can always follow up. They've got their contact information in as well. You can reach out to them directly, but I'm going to hand it over to Tim. We're going to just do a quick little teaser as we move into summer before the fall hits, and we're going to do our full helping students experiencing homelessness training. So Tim, take it away.
Thanks so much. Awesome. So hard transition. We are talking to everybody in this moment, but especially those who work with families and youth experiencing homelessness that want to make sure that their K through 12 students get access to what they need to be educated and to graduate. Speaking as someone who is a McKinney-Vento student in high school, I recognize that there are many people who may not know precisely what youth are entitled to and what schools are required to provide so that students can meet their educational needs. Because of that, we are in a great position where we have the capacity to provide an annual training for community providers in which McKinney-Vento liaisons do come, which is a fantastic linkage, and basically provide a number of different reminders of the law, reminders of existing resources in community, and just a bit of networking within a county as big as King County so that youth and family providers can get what they need to support their students experiencing homelessness. So I do want to share that we have a few need to know items that we want to share with people over the summer before the school year starts in September. But we do have a full training on the rights of McKinney-Vento students on October 1st. So we're going to be holding that after the school year has started, obviously, and we'll share that link to register for that training in the chat. Thank you, I see it right there. But we are going to spend just a moment on giving our providers a few need-to-know tips that can set people up before the school year starts. And for that, I'll pass it back to my colleague, Jody.
Thank you, Tim. Yeah, as Tim mentioned, we usually like to hold this training before the school year starts, but schedules being what they are, it didn't happen this year. So we're just going to give you a little teaser and some key things to know as you're working with your students and families. So first of all, the McKinney-Vento Act, it's a federal act, it's a mandate, it is an underfunded act. So that is a reality that families, students, school districts, and schools are facing and navigating. That being said, you all are fierce advocates. It's why you're here. So we want you to be equipped with the knowledge to help your students and families get what they need. So McKinney-Vento defines homelessness as children and youth who lack a fixed, regular, or adequate nighttime residence. And probably not surprising, you know, this can be doubled up. This can be living in hotels, motels, campgrounds, trailer parks, emergency or transitional shelter or housing, kiddos that have been abandoned in hospitals, you know, living in vehicles, public spaces, you know, unsheltered, places not meant for human habitation. And it also includes migratory children and youth that are in any of those situations. So, you know, it's a pretty good broad definition of homelessness. We like that. The other thing to be really aware of is there is a school of origin mandate. And so what this means is that students can return to the school that they were last attending when they were permanently housed or that they were last enrolled in. This includes preschool, and it means immediate enrollment. So, for example, if they were enrolled in their school in Kirkland, but they were able to find some type of housing shelter in Renton, but their community is still in Kirkland, their you know, EIP, which is a, you know, educational plan that makes accommodations for students, is all well set, and everybody knows in that school in Kirkland, they're the star athlete on their school team in Kirkland. They can go to that school in Kirkland without delay of enrollment. And then the last thing I want to say is that transportation is required to remove barriers. So it is not left to the family or the student to figure out how to get from Renton to Kirkland. It may not be a typical school bus, but there are the school district and the McKinney-Vento liaison will work to make that happen. What I will say, just in the sort of spirit of navigating the realities, it is an underfunded mandate. And so there can be delays, even though there's not supposed to be under the law. And I think what I want to impart to you all is finding the balance between understanding that the school or the liaison might be doing what they can to figure out the solution. And, you know, 2 weeks into a school year is not okay for a student to be missing school and not have the resources that they need. So, you know, making sure that you have the ability to advocate for the folks you're working with to make sure students are enrolled in school where they need to be, getting the transportation, and that burden isn't falling on the student or the family. We have on our website a statewide list of McKinney-Vento liaisons, but we also have gone through and actually put the ones that are specific to King County. So we're going to throw that link into the chat for you all. It should include all of the districts in King County. If it's missing something, please let us know and we will go back and redouble our efforts there. And the last thing I will say is that usually there is a district liaison and then there's often a school contact. So it might be helpful to reach out to the liaison and then find out who the best contact is at the actual school. So we are going to dive into this much deeper on October 1st. So please join us, register. We'll remind you as we get closer to that training date, and throw some questions or comments in the chat if there's something you want to see as a part of that training, because it is not set in stone yet. So we can accommodate what y'all need to know and hear about. So on that note, and for the sake of time, I'm going to move us on to our next section, which is coalition announcements. And I'm going to pass it over to Allison really quick here. But as I talked about at the top of the meeting, you know, we are all still processing what the Supreme Court decision around grants pass means, how this is going to impact the folks we're working with. And we don't have a lot of time to have a deep conversation around this or to answer a ton of questions, but we do want to know what you all are needing to understand more about, your reactions to it, questions about it. So on that note, I'm going to pass it to Allison.
Thanks, Jody. Hallie, I just sent you a little note because I realized there's something that could be useful for our folks today on the call. Thank you. I think when last we gathered in a membership meeting, it was, of course, towards the third week in June, and we knew that a Supreme Court decision would be coming out by the end of June, which indeed it did, in a very last minute week of mostly appalling decisions from the US Supreme Court. So we are not surprised that the Supreme Court issued the decision that it did in the Grants Pass versus Gloria Johnson case. I asked Hallie to share with you all the link to the message that we sent out to everybody the next day that gives you a little bit of information about how we are going to proceed. As you won't be surprised to hear, everyone across the West Coast and across the nation was hoping that we would get a not worst case scenario decision, which would essentially have given us the opportunity to continue working in the mode that we're working in right now, which is not great, but at least the Martin versus Boise decision stood. Effectively, the Martin versus Boise decision from the Ninth Circuit Court has now been overturned with this Supreme Court decision. What does that mean? What it means is that constraints are removed from local jurisdictions that wish to either enforce existing laws or pass new laws that punish through fines, arrests, jail, or threats of those things, people who don't have homes and who are existing in public spaces. But one of the things that I've always said about the Martin versus Boise decision is that law did not enforce itself. So you all are painfully aware of all the ways in which people experiencing homelessness are already subject to punishment in formal and informal ways. Also of note, a reminder to all of you, the ACLU of Washington has brought a case, Kitchen versus Seattle, against the city of Seattle about its current practices of providing zero notice or offers of assistance to people experiencing homelessness within the city of Seattle. And that case is has been brought in state court. The Coalition on Homelessness and 3 unhoused Burien residents brought our case against the city of Burien's unjust banishment ordinance, also under Washington state law. We have state protections that we are relying on as we build our case. So the Supreme Court decision has not changed those things. In fact, it has made them even more crucial as we go through testing what we can do in Washington state. Just because it's possible to pass and enforce terrible, punitive, counterproductive laws that make things harder for people and do nothing to help them, doesn't mean that local jurisdictions should. And indeed, we're looking at all the ways that we can ensure that we don't make things worse for folks who are living outside. I'd like to really take some time, rather than doing an analysis of the decision, to take a few minutes to hear from you all what questions you might have, what are your real on-the-ground observations or concerns, because we are also in information gathering mode. The coalition, together with legal allies and policy allies, is exploring all of the options that are available to us, including developing proposals that will basically stop the bad stuff and double down on the good stuff that we know folks need. So please feel welcome, especially if you're someone who maybe is new to the coalition, if you're a direct service provider, if you have personal experience of homelessness, please feel welcome to raise your hand or unmute yourself. I can't see everybody right now on one screen, or put something in the chat. And just know we're not flipping a switch here. We are going to take a stand in Washington State and make sure that what we do is better, just as Washington State did to protect people's bodily autonomy and right to access healthcare after the Supreme Court overturned Roe versus Wade. We think Washington State can take a direction that is better for all our residents than what the Supreme Court decision might suggest. Okay, so I see a question here in the chat from Joseph Rutenberg. Should we be developing a backup plan of action for clients who are currently sleeping in their vehicle or on the streets? Well, always. I mean, I am not entirely sure, Joseph, what you're thinking about. So if you're in a place where you can come off mute and describe what you're meaning by a backup plan, please feel welcome to do that. Or I'll put my email in the chat and you can follow up with us.
I can speak if you don't
Oh,
mind.
there we go. Thanks, Joseph.
So I'm a rep of rehousing. I'm just really worried about possibly getting my clients incarcerated, right? Because that's another barrier that could pop up. And if they don't have any of that before and they get that now, that's going to show up on the record and that makes my job harder. So I'm really worried about my clients that are currently in their vehicle. They don't really have a place to go with their family. Like a lot of the car camping spots aren't really safe and there's not a lot of space and they have to call for intake, same thing for shelters and all that. So I'm really worried, like, where should I tell them to go? Where should I be checking in with them and seeing like, hey, do you have like something with this new court case and, you know, the ruling, do you have something in case worst comes to worst, like you feel like you might get thrown in jail or told to leave, right? Yeah, that's really what my worry is.
Thank you. Thank you so much for articulating that. And you are right to be worried. And also, I think, you know, we need to all recognize that there are many, many ways in which people who are forced to live outside in public spaces, including those who may be in vehicles or tents, are already subject to interactions with law enforcement that could lead to a number of outcomes, potentially including arrest and jail. This is just one more. And we also don't want to spread panic. There's a lot of uncertainty on many fronts right now. I would say your clients, depending on which jurisdiction they are in King County, or if they're in another jurisdiction, are probably familiar with what laws are being enforced on the ground in that community. And I think it's really good to have a conversation with them about, you know, have you had interactions with law enforcement? What is your option if you are told you are not allowed to be where you currently are? But other than that, I think at this point, we don't want to add to people's sense of strain and despair. We are trying to figure out things that we can proactively do as advocates in the policy realm to help local jurisdictions understand that those kinds of procedures, first of all, will still be challenged under our state laws. And second of all, those procedures are enormously wasteful and counterproductive for the reasons that you yourself stated, Joseph. Makes it harder for people to be able to access jobs, housing, and other necessities. I think I'm being given the high sign by our fearless leader, Jody, that we don't have a huge amount more time here because, of course, there's a major primary election coming up, and Tim is going to speak about that. And I'm at my parents' house in New York where there's a real loud landline. So I'm going to mute myself and then come back and put a few things in the chat. Thank you so much.
Thank you, Allison. Hallie Willis had a beautiful suggestion behind the scenes. Please keep throwing thoughts, questions, things you want to know more about into the chat. We will collect all that. You can email Hallie directly, and that will really help us understand how we can support our community and what we need to be doing as a coalition around these issues. And a couple of you have thrown in other cases that you're concerned about. It's all in the same realm of not wanting to criminalize people simply for not having a home. So really, thank you all. Mull on it, keep throwing it into the chat. And Hallie, if you wouldn't mind just throwing your email into the chat, that would be fantastic. Thank you. Tim, take it away for voting.
Excellent. So, as we've all been discussing, and as Allison eloquently stated, this is something that we're still piecing apart, and we're still working behind the scenes to respond to. It's something that will likely affect different jurisdictions in different ways. One thing that is certain about what we can do as people to advocate on behalf of our unhoused neighbors is voting. Because by voting, we can ensure that we have people in different levels of different jurisdictions and different levels of office that can support the dignity and humanity of our people living outdoors and in unstable situations, and support programs like human services and affordable housing that we know are effective. Thankfully, there is an upcoming August 6th primary election that allows you to pick your choice of candidates that can help to reflect your values. We have a ton of things on the election that are, of course, leading towards a general election. We are voting for U.S. Senator, U.S. Representative, Governor, Secretary of State, Attorney General, and many, many legislative district senators and representatives that represent you, that represent the legislative agenda that we are likely going to embark upon together. So vote with your values, please. Obviously, we can't specifically tell you how to vote in this bucket of work, but we do encourage you to vote your values. And with that, I want to give you some resources so that you can share with others, including people who are unhoused and your housed neighbors, to make sure that they are eligible to vote and know resources available to them. So, like I said, the primary election, the final day of the primary election, when you must submit your ballot, is Tuesday, August 6th. There's still plenty of time to register to vote. Go online to see how you can register via mail, in person, and online. Know that in King County and in Washington State, we're in kind of a uniquely progressive situation where we can register to vote and cast our ballot on the same day. If a person misses the registration via mail or online deadline, you can go to a number of vote centers in King County. There are approximately 6. Sorry, I'm dropping links again, and I'm gonna let my colleague continue. I'm just on a roll with that today. I'm gonna put my hands up. So there are lots of ways to register to vote, including on up to and on election day in person. Your ballots have also been mailed, I believe, this week. If you haven't already received your ballot, you can contact King County Elections for more information. You can also go online to print your ballot. You can print your ballot an unlimited number of times as long as you only submit one ballot. Of course, I have tested this feature. It's very handy. It's great for people who move around or have multiple addresses, especially our unhoused neighbors who may be in transition between different mailing addresses. This is a wonderful feature to share. And then I also just want to share, obviously in a mail-in state, there are multiple ways to submit your ballot once you've filled it out. We have drop boxes all over the county that I encourage you to scope out to see what's closest to you. Of course, if you have a physical address, it's easy for you to just pop that in the mail as well. So please vote your values. Know that voting can affect change. It has in King County in terms of public health and affordable housing resources, and will again. So I just want to remind you also that the coalition is happy to consult with you to inspire confidence in your vote and to share existing resources. I'm going to put my email in the chat. You are welcome to reach out to me to hear about what voting resources we can share with you. And with that, I want to transition to member announcements. If we could please share that slide, that gives our members a prompt to share. This is a segment that can allow anybody to share information that is relevant to new programs, new resources, updated programs and resources that can assist our unhoused neighbors and their service providers. We want to highlight and prioritize our service providers, of course, because service providers are busy and we want to provide this meeting to efficiently provide resources to allow folks to do their jobs. There are some guiding questions on the slide there that I would encourage people to refer to, such as, who these updates or new information may affect, eligibility, how to access, and if there are any relevant deadlines. We do have a speaker bookmarked for first place. I would like to turn it over to Jennifer Johnson with YMCA Lifeline. Thank you so much for being here. All right, take it away, Jennifer. Oh, Jennifer, you are muted currently. Oh, and I see Cami also from YMCA unmuting.
Yes. Thank you. Thank you for having us. Cami, take it away.
Yeah, so I will just give a brief overview. We're going to be talking about a new pilot program through the YMCA called Lifeline. And this is uniquely kind of like a pre-crisis intervention. So hoping to stop any sort of challenges that participants may be having before it escalates to a crisis, specifically for youth and young adults ages 12 to 25. Throughout the state of Washington. So this isn't just uniquely King County, this is the state of Washington entirely. While we do prioritize Spokane and Pierce County, anyone in the state of Washington can access this. And it is uniquely designed for those who are experiencing those challenges, who have exited some various forms of public care systems. So think foster care, inpatient, juvenile justice system, or have experienced homelessness in the past. There isn't like a time frame of when they had to be exiting that. It's just at any point in their history. So if they experienced that when they were a little kid, but they're now having some present challenges, we can still work with them. It doesn't have to be within like the past year they had exited those programs. It's at any time. And our program works with like case management, resource navigation, peer support, and we also do have flexible funding to help support any challenges such as like grocery cards, working with rental assistance and that kind of stuff. So Jenny, if I may have missed anything that might be pertinent, feel free to add to that, but that is our new pilot program through the YMCA.
Yeah, Kemi, you covered most of it. So I did drop the link to apply in the chat, and folks who apply or call will get me first, and then Cami is our case manager for cases that are a little more complex. For the deadline, there is really no deadline. We will continue to work with folks until they are completely assisted. We do have this program running through spring of next year, and it's a pilot program. So if we can prove need, then it is likely we will get further funding. But for now, it's going through spring of next year. Any questions?
Please feel free to share your questions verbally or put them in the chat. Thank you so much, Cami and Jennifer. In just a moment, we will stop recording if anyone wants to speak and just not exist on a recording. I think now is the time to stop the recording.